Good evening and welcome to this session on session of Journal Club on a paper which actually reiterates what is pretty well known. It's a comparison between breast conservation surgery and MRM. But the interesting thing is that it is from the southern hemisphere. So it gives you, and it talks specifically about quality of life. So most of the papers we read are from the northern hemisphere, where the attitudes of the women there may be very different from what it is here. And so for me, it was a paper from the southern hemisphere, and that was interesting. And the second thing is that it did have several points which could be critiqued. And so I requested Indraja to choose that among the 3 or 4 that she had sent me. Over to you, Indraja, to give the presentation.
Am I audible, sir?
Yes, you are. Slides are visible.
Good evening to everyone. I'm Dr. Indraja, second year surgery resident.
Audio is less, sir.
The little volume is a little low. Can you get closer to the mic or increase the volume or whatever, please?
Good evening to everyone.
Much better. Thank you. Yeah.
I'm Dr. Indraja, second year surgery resident in Saga Hospital. Today, I'm going to discuss about the effect of breast conservating surgery and modified radical mastectomy on quality of life in case of early breast cancer patients. This study was conducted by Hing Liu et al. It is a retrospective study accepted on 1st July 2021 and published in Food Science Technology in Campinus. It has an impact factor of 1.44. Breast cancer, it is the most common malignancy and it is one of the leading cause of cancer death among the women worldwide. And most of the breast tumors are arising from the glandular epithelial cells, and most common is being invasive ductal carcinoma, which accounts for 70% of all breast cancer. And the other types includes medullary breast cancer, tubular inflammatory, which are rare types of breast cancers. There are different risk factors for the development of breast cancer, which includes longer menstrual periods, use of oral contraceptive pills, family history, high body mass index, older age, and exposure to the radiation. Because of the improvement in the imaging modalities and puncture technology and women's health awareness, the early detection of breast cancer has been greatly improved compared to the olden days. And the prognosis of the breast cancer depends upon the early diagnosis and the thorough treatment. In early breast cancer, surgery is the primary treatment of choice, and modified radical mastectomy is the most preferred surgery But breasts are important secondary sexual characters of the women, and because of the MRM, breast aesthetics are severely affected, and the quality of life also severely impaired after the mastectomy. And the biomedical model, which was focused on biochemical factors that leads to the onset of the disease, it ignores the social and psychological factors. Later on, Angel proposed a biopsychosocial model to replace the biomedical model, which consists of different factors like psychological, biological, and social factors for the development of the breast cancer. And till mid 1980s, MRM was accepted by most of the patients. Later on, a newer therapeutic option was came in, that is breast conservative surgery, in which tumor along with normal tissue around the tumor was removed, and it preserved the breast that ensures effective resection of the lesion. And in breast conservative surgery, the shape and appearance of the treated breast was preserved. In order to reduce the post-operative recurrence, axillary lymph node dissection was performed through a separate incision, and all the patients received radiotherapy, chemotherapy, and endocrine therapy followed by surgery.
Just one sec. Just one sec.
Yes, sir.
Pavan, can you tell us the classical indications for breast conservative surgery?
Am I audible?
Yes, you are. There is some disturbance. So, yeah.
Sir,
Go on.
cosmetic, sir.
Now, what are the requirements before you can offer somebody breast conservation surgery?
So if the size of the breast tumor is small,
What is it?
it's less than 2 centimeters.
Is it 2,
3 centimeters.
3, or is it the T stage that is important?
T stage, sir.
What T stage?
In early breast cancer, like T1
Yeah.
and T2, sir.
T1 and T2. All right. And T2 is what?
Sir,
Hari, you're an exam going student, right?
Sir, 2 to 5 centimeters.
Yeah. Okay. And is that the only factor, or is there something else that is important? Is just the T stage, or is it something else that is important before you can offer BCS?
Sir, the multi focality, sir.
Yeah.
Sorry, multi-center.
Yeah, just about the size I'm talking about. Is size of the tumor only important, or is something else is
No,
important?
sir, location, sir, from the distance from the nipple areola.
That's one. Okay, location. It has to be
And the
some
size,
distance from the nipple areola, because you have to preserve the complex and then excise it. Agreed? Yeah.
the size of the breast, sir. Small
Very
breast,
good.
we can-
That is the one I was looking for. If you have a small breast, then even if the tumor is within the T2 range, you cannot offer a BCS. Okay, what else? What are other requirements for BCS?
um, sir, patient, it's a small monocentric tumor, sir.
Okay.
And
It is known to be multicentric.
yes, sir.
Then you cannot do that. Agreed.
And patient compliance, sir.
Yeah. Compliance for what?
I mean, follow up
Radiotherapy.
radiotherapy.
Okay.
Yes, sir.
Radiotherapy is a must after BCS. So if the patient is dead against radiotherapy, then you cannot offer them BCS.
Already
Right.
undergone
And-
irradiation.
And and if you have a marginal tumor, is there any way you can try and give them BCS? A marginal tumor in terms of size, can you downstage it in any manner?
A neoadjuvant.
Yes, you can give them neoadjuvant and bring them down to a stage where there is BCS. All this is done for better cosmesis and better body image.
Yes.
All right, please go on.
Sir, education is important, sir.
Yeah. Yeah.
In breast conservative surgery, to consider education also is important.
Yes, agreed. Yeah.
Okay. Okay.
Yeah, go on.
Okay.
You will see in the chat box that these points have been covered, have been mentioned by Nishant and Naz madam. Yeah, go on.
Okay.
Yeah.
And the aim of this study to see the prognosis and post-operative quality of life between the two surgeries, and hoping to provide strong evidence to promote breast conservative surgery in China. They included a total of 200 patients with early breast cancers who received surgical treatment in their hospital from January 2015 to Jan 2017. And they included patients with single mammary tumor diagnosed through molybdenum target mammography with a pathological biopsy with a tumor diameter of less than or equal to 3 centimeters and tumor areolar distance more than or equals to 3 centimeters. They excluded patients based on distant metastasis and patients with severe hematological and immune disorders, and who had other malignant tumors and who lost follow-up because for other reasons. And breast conservative surgery was performed with through 2 separate incisions in the breast and axilla. The axillary incision should be parallel along the axillary floor, and the length of incision should be 6 centimeters for the convenience of the axillary lymph node dissection. If the lesion in the axillary tail of Spence, the incision should be according to its specific location. If the lesion in the upper hemisphere of the breast, arcuate incision was given that is parallel to the areola, and the lesion is present in the lower hemisphere of the breast, radial incision was given through the center of the nipple. And extended local resection and quadrantectomy was performed to remove the complete lesion with a 1 to 2 centimeters margin of normal tissue. If the lesion involving the Cooper's ligament or skin, we have to remove completely epidermis, or we should preserve the epidermis appropriately. And they have sent the specimen for the frozen section and pathological examination. If the margins were positive, they did extended resection with a margin of 5 centimeters and again sent for the pathological examination. And if the margins were remained positive, BCS was replaced by the modified radical mastectomy. And lymph node dissection was done, removing the lymph nodes along the leading edge of the latissimus dorsi and to the deep surface of the pectoralis minor and those along the axillary vein. And vein was placed in both axilla and at the incision site in the breast, and operation was completed layer by layer. And modified radical mastectomy is performed through the fusiform incision, and subcutaneous flaps were raised, and pectoralis major and minor vessels identified, and excision of the flap with a breadth of 3 centimeters around the perimeter of the lesion was conducted, and vein was placed, axillary lymph node dissection was done, and operation was completed layer by layer suture. And after the surgery, all patients received postoperative radiotherapy, chemotherapy, and endocrine therapy. And the chemotherapy was adjuvant chemotherapy with taxotere, epirubicin, and cyclophosphamide was given after the surgery. And 1 month postoperatively, patients received conformal radiotherapy at a dose of 45 to 50 gyrate to the whole breast and 10 gyrate to the tumor bed. And of endocrine therapy, those patients, premenopausal patients with ER and estrogen and post-progesterone receptor positive status received tamoxifen twice a day for 5 years, and postmenopausal who had ER and PR positive received letrozole once daily at a dose of 2.5 mg for 5 years.
Just hold on there.
Yes, sir.
I need to clarify a few things about the procedure, and there are some questions in the very pertinent questions in the chat box as well.
Yes.
Okay. Now, have you read about BCS, Indraja?
Yes, sir.
Yeah. Is what they have described pretty standard, or is it something different?
So in breast conservative surgery, we'll remove tumor along with the 2 centimeters margin, so 1 to 2 centimeters margin.
Okay.
But generally, we don't know the lymph node dissection, sir, in BCS.
No, just about the lump itself. We'll go to the lymph nodes later.
Yes.
You mentioned 1 to 2 centimeters.
Yes, sir.
The minimum required is 1 centimeter. You're quite right. But the optimum required is 2.
Yes.
But what did this paper say? You yourself read it out. Go back 2-3 slides. This is why you must focus on what you read and analyze everything that you read in a journal club. It has to be in detail. Okay. So what margin did they give? 1
to 2 centimeters margin of the normal tissue, sir, was removed along with the lesion.
Is it? Just there is some mention of 5 centimeters. What is that?
Sir, that is after frozen section. If the margins turn out to be positive,
yes,
then they go for 5 centimeter margin.
Correct. Is that the standard? That's a question. That is still not the standard. Yes. You don't need 5 centimeters.
Okay.
Okay.
Yes,
you can then say, how you can guesstimate as to what your distance is.
Okay. And
then take another 2 centimeters and do it again, because 5 centimeters. What is the disadvantage of taking an extensive margin?
So like most of the breast tissue were like,
yeah, you end up with a quadrantectomy or even more, and then the basic purpose of giving cosmesis itself is lost.
Yes.
Isn't it?
Yes, sir.
Okay. And would you do an axillary dissection in all the patients like these people have done? What is the standard of care now?
Even if nodes are detected in any imaging, then only we'll do the.
Are you going by imaging for your decision?
Or clinical examination.
What is the standard of care today for axillary dissection. So much has been talked about.
Palpable lymph nodes.
No, no,
Frozen section.
no.
Sentinel lymph node.
Sentinel lymph node.
Sentinel lymph
Thank
node,
you.
yes, yes.
Thank you. If you do not mention sentinel node today, it is inadequate treatment or non-standard treatment. So you do not, unless your palpable lymph nodes where you can do a dissection, if you have impalpable lymph nodes, clinical N0 status, before you dissect the lymph node, you have to do a sentinel node biopsy. Okay?
Yes.
That is something which they have not done. And there is a question in the box. What is molybdenum target mammography?
Like that is the anode, so that create X-rays.
What is an anode? Yeah, it is a way of sensitizing the tumor, as it were, for better delineation. Okay.
Yes, sir.
So that is one modification to get a better definition, and that is what they have used. Okay.
Yes.
And there is also a question from Naz, madam. What is epidermis retaining? Ravi, you want to take that question?
Epidermis retaining, sir.
Yeah, in their raising the flaps for MRM, they mentioned that.
I'm not sure what that means.
Yeah, I also wasn't sure, ma'am. I think they actually mean dermis also. I mean, they have to retain the skin with its circulation. They cannot take off the dermis. Otherwise, if they hold only the epidermis, that will necrose. There is no two ways about it. I think
Sir,
it probably
probably what they meant to us, where the site of the tumor is,
Mhm.
if it is not puckered, they won't take
Yeah.
out too much of the skin on top of
Yeah, I mean, that's the whole skin.
the whole skin.
Correct.
They will only take a part of the skin.
Correct.
That is what they mean,
Yeah,
probably.
fair enough. So they will not take out all the skin around the whole tumor if they find that the skin is free of tumor. That's probably what they said. That is pretty much the standard. Okay, Nishant has a question for Indraja.
Yes, sir.
Why tamoxifen in only premenopausal and not postmenopausal?
Sorry, sir.
What is the
Sir, it is,
mechanism of action?
Estrogen, it acts against estrogen receptor, sir, tamoxifen.
Yes, it is an anti-estrogen
Estrogen.
medication.
Yes, sir.
So how much estrogen would you find in the postmenopausal women?
Like
Less than the
yes, sir.
premenopausal,
Yes, sir.
right? So that is one of the logics that they may be used. But as you know, tamoxifen is also used in the postmenopausal, but it is the choice of the local medical oncologist to decide on the regime, and that's probably what they used. And the important thing is they use the same thing in all the patients. That is the important thing.
Okay, sir.
And another, go
Sir,
on.
can I just clarify that point, sir?
Yeah,
Tamoxifen also has estrogen-like action, a little
Yeah.
bit of estrogen-like action,
Yeah.
which is another reason why they probably use it only in
For
the
exam,
women.
can I come in, sir? For the
Yeah.
exam point of view,
Yeah.
Tamoxifen is a selective estrogen receptor modulator. So certain places it acts like anti-estrogen, certain places it acts like estrogen. So
Yeah.
in the breast it acts anti-estrogen,
Yeah.
but in the uterus or in the endometrium it acts estrogen-like.
Yeah.
So
That is
it
why-
has a risk of endometrial carcinoma. In premenopausal, majority is from the ovary, the estrogen. That is why you're going to use tamoxifen. Whereas in postmenopausal, the estrogen, whatever is produced, is because of fat conversion. That is peripheral conversion of fat into estrogen. That is why in postmenopausal, in order to mitigate or reduce the risk of endometrial carcinoma, you can stop tamoxifen and instead just give them anastrozole, which is a
more selective anti-estrogen.
correct. It only blocks the peripheral conversion and it doesn't inhibit estrogen action per se.
Agreed with that. Yeah.
Thank you.
Sir,
Pathological margin. Sorry, go on, Ravi. you have
sorry,
something to add?
about the targeted molybdenum, this one mammography.
Yeah.
You are absolutely right in what you said. I think the other advantage is apparently it picks up the DCIS and LCIS better if you do a targeted molybdenum thing.
Very nice. Okay. All right. Pathological margin. How do you define?
Sir, those are the margins in the specimen, sir.
Mhm.
Generally, the margins should be like uninvolved, should not involve, sir.
Yeah. Naz, do you have anything to add there?
Just wanted to clarify those points I've got them. Yes.
Yeah, yeah. Okay. You also mentioned AL and B. What?
That is SLNB, sir. That was by
Okay,
mistake.
okay. Yeah. So you're answering that.
Yes, sir.
All right.
And
So
that pathological margin, I just wanted to confirm, sir.
yeah,
No tumor on the
no tumor
ink
on
mar-
pathological section.
Yeah,
And this
ink-
is
ink-
where,
inked margin.
yes,
sir.
this is that I
Yes.
was about to say that inking is very important. So when you send the specimen, you got to ink the margins and then send it across. Also orientation. Also remember that whenever you send the samples, you must have some method in which you can show them which is the superior margin and which is the lateral margin. And then the pathologist then will know, they sample all the margins and they'll be able to tell you if there is involvement of a given margin, so that you can go back and have a wider excision in that aspect, in that segment of your previous resection. So marking, inking and marking with sutures is very important when you send a sample to the pathologist. Okay, so
Okay.
go on. Any other questions to be clarified or points to be made?
Sir, one more thing, they've
Yeah.
kept drains both in the BCS area as well as the axillary lymph node dissection area.
All right.
So ideally in BCS, you don't keep the drains in the breast area. Otherwise, the cosmesis will go
You're
away.
right. It causes a lot of puckering and sort of
Puckering.
sucking in. You're right. You don't put deep stitches as well. Neither
Correct.
do you put a drain unless the cavity is very big, in which you're concerned about it. But yes, by and large, you don't necessarily have to put a drain in the BCS. All right. The other important thing is, which, earlier we used to say that if you have done an MRM, there is no need for radiotherapy to the area of the breast. But the later recommendations, guidelines mention that you need to give radiotherapy even after an MRM, unless you have a specific contraindication like an underlying lung disease or something like that in the patient. And so they have, in this study also, they have given DXT to both MRM and BCS arms. Okay.
Yes, sir.
All right. Continue.
Yes. And they measured outcomes in the perioperative and postoperative period. In perioperative outcome measures includes operation time, incision length, intraoperative blood loss, and hospital stay. And the postoperative complication rates that were measured includes incidence of subcutaneous effusion, subcutaneous hemorrhage and flap necrosis, infection, and upper limb edema in total incidence. The postoperative aesthetic outcomes, they measured 1 year postoperatively. These breast aesthetics were evaluated using Harris 4-stage subjective evaluation method. And based on this method, aesthetic outcomes were classified as excellent, good, fair, and poor. In excellent, the patients will have symmetrical breast of similar shape and texture, and the normal color with a nipple height difference of less than or equals to 2 centimeters. And in good category, the patients will have symmetrical breast of similar shape and size, and the normal nipple height difference between 2 to 3 centimeters. And fair, in fair group, the nipple height difference is around 2 to 3 centimeters, and the light color, having symmetrical breast of slightly worse texture. And in poor group, patients will have non-asymmetric breast of reduced size and markedly worse texture and light color with nipple height difference of greater than 3 centimeters. The rate of good to excellent aesthetic outcomes were calculated as excellent cases plus good cases by total number of cases into 100.
If I asked you to summarize what you have said about these outcomes, what would you say?
Sir, they measured outcomes in the perioperative period, postoperative period.
All that is
aesthetic.
understood. The
Yes,
answer I expected was they have an objective measure of the aesthetics.
Yes.
Yeah, that's an important point. They have a standard scale, as it were,
Yes, sir.
to measure the aesthetic outcome of their operation.
Yes.
Okay. Right, go on.
And the recurrence and mortality rate were measured at 1 and 3 years postoperatively that conducted in outpatient clinic to collect the recurrence and mortality rate. And recurrence was observed in molybdenum target X-ray and ultrasound examinations. And telephonic survey was made to obtain relevant information from the patients with incomplete follow-up.
Yeah.
And the postoperative quality of life at 1 and 3 years postoperatively was measured by 2 different questionnaires, which includes quality of life questionnaire 430 and quality of life questionnaire breast cancer module 23. So,
just yeah, go on.
Yes, sir.
Go on.
Sir, yeah, yes, sir. Sir, these are the quality of life core questionnaires, sir. This includes the following questions that rated scored according to 1, 2, 3, 4, sir. This consists of different questions.
Yeah, these are general symptoms. Okay.
Yes, sir.
General quality of life. Yeah,
Yes.
go on.
And the quality of life breast cancer modules are 23. This consists of different types of questions related to the patient's personal life.
And specifically, there are questions designed to assess the comfort or discomfort levels of the breast.
Yes.
Okay.
Yes.
And that is where, so in other words, quality of life scores, what do they mean to you? That's a very important part of this paper. That's why I'm going to spend a couple of minutes on it. What does a QOL mean to you as a surgeon?
So quality of life of like how much the surgery is affected on the patient's life. Like,
okay. Like what aspects of life?
Whether they are able to carry out their normal activities or not.
Very good. Yeah, and if can the same QOL score be applied to all the operations that you do?
No, sir. Like,
yeah, there
different
are
surgeries will have different.
Correct. So there is one general quality of life score, which tells them about the general behavior, and there is another score specific for the organ that is operated on. It be it the breast, the stomach, pancreas, colon. It's like that. So these in this paper, they have correctly used both quality of life scores, which would give them a comprehensive idea about what the real status for the patient is. Okay, that is one nice thing about this paper. We'll come to that when we use the critique. Yeah, go on.
And the main contents of this questionnaire includes emotional functioning, social functioning, body image, sexual function, and global quality of life.
Yeah.
And they analyzed the data analysis were performed with SPSS 24 software, and chi-square test was adopted for the comparison of enumeration of data expressed as case percentage, and measurement of data with normal distribution were expressed as mean plus or minus standard deviation. The independent t-test was used for the comparison between the two groups, and paired t-test was applied for the comparison within the same group. And a significant level of alpha was adapted, and probability less than 0.05 considered statistically.
All right. Now, at this point, I would like to, there's some disturbance with something.
Pavan or laptops?
Pavan, is it? Yeah. Okay. Anyway, I would like to welcome Dr. Sopimat. Very nice of him to join. Ram Krishna, senior people have joined. And I think it's a big value add to the discussion when we do this. But, and also Ratna Chopra, ma'am, can you tell us something about yourself?
Yeah, sir, I'm Dr. Ratna Chopra. I'm HOD surgery at Indira Hospital, Delhi.
Oh, I met you at the meeting yesterday.
Yes,
I thought it was you. Extremely nice of you to have joined in, ma'am. Your inputs will be very valuable in this discussion. Very nice of you to join. Thank you.
I really enjoyed listening to the discussion, sir.
Thank you. Thank you. Let's start with the students first. What would be your critique? Pavan, can you tell us what are the good points and not so good points in this paper so far? Pavan, are you there? Can you unmute yourself? All right.
Sir, am I audible, sir?
Yes, you are. Please go on.
So the good point for this article, the study is, it's a good and recent study, sir,
Okay,
and it's in a relevant topic,
right.
and they clearly defined the endpoints.
Mhm.
And the against for this is it's a retrospective study, sir.
Okay, so in your understanding, what are the disadvantages of a retrospective study?
Okay.
All right, Hari.
Sir, the level of evidence compared to prospective study will be less, sir. It will be observational, sir.
Why?
So biases will be there, sir. So recall
Okay.
bias.
What are the kinds of bias that you will find?
For example, recall bias, sir.
Okay, very
And
good. Selection bias will be
selection
there.
bias.
All right. What else? There will be lack of data
Yes, sir.
because it's not a uniformly collected data, so there can be inconsistencies in the data,
Yes, sir.
and certain data points may be missed
Yes, sir.
because the event has already occurred and you can't go back and collect the data. Whereas in a prospective study, you get all the data points. So
Yes.
it's always better to have a prospective study. Yes. So it's a retrospective study. So that is one of the disadvantages. Yeah. Okay, go on. What else is the other negative points in this?
So
Hari?
right.
Yeah,
Yes.
go on, Hari.
Sir, other than I'll just tell about the PowerPoint, sir. Whatever Sir Pawan missed.
Yeah.
Sir, other than what he mentioned, the criteria are good, sir. They included the inclusion and exclusions are good. So
Okay.
they excluded the immunocompromised and etc. etc. So both the criteria are good.
Yes.
And the procedures are both clearly explained. Like many of the papers you don't explain, so clearly explained here. That is
Right.
good.
Right.
And the important aspects of quality of life, that is measuring, that is good.
Yeah.
So these are the good points, sir.
Right.
And against the paper, so like you mentioned, retrospective study. And so regarding the surgeries, they mentioned the procedure, but like surgeon who did it, other details could have been there, but they mentioned the surgeries.
Very good. They didn't tell you that the surgeons are of the same experience
Yes, sir.
or similar experience. That's an important point. Yes, go on.
So that was not there.
Mhm.
And like one point I wanted to mention that already been pointed out, so the drain placed up. So I was not
Right.
sure. So these are the points I have collected.
All right. Can I now come to the seniors, please? Niranjan, you have anything to add?
Sir, one thing is about the intention to treat principle. Probably it was a retrospective study. I don't think they could have followed it up to the T.
Yeah.
But where they've excluded, it is very not very specific. The
Yeah.
exclusion criteria. In one sentence, they say with those who did not undergo designated treatment
Yeah.
and incomplete follow-up. And in the discussion also, they have not mentioned clearly about their protocol. How did they exclude? And in one sentence, they say where they've if the margin was more than 5 centimeters, they took the patient in. They did the MRM. So they have not mentioned whether they have included that patient in the BCS criteria category or in the MRM category to analyze the data.
All right.
So
there is some bias in terms of selection.
Selection.
In other
Yes.
words, yeah. Okay.
Yeah.
Fair enough. Right.
And in some areas there is grammatical errors, and probably they have mentioned it as neoadjuvant chemotherapy.
Right.
Probably what they want to mention it is adjuvant chemotherapy in post-operative treatment.
Yeah.
Yes, sir.
That's one thing. Yeah. This juncture, I see Mrs. Madhumita also here. Welcome, ma'am. It's very nice of you to have joined in.
Good evening,
Okay.
sir.
Good evening. Good evening. Can I invite comments from Dr. Sopimat, please?
No, Lakshman, I'm just joining in between.
All right.
I'm doing multitasking, so but
All
I'm
right,
enjoying the
okay.
discussion. Yeah,
Okay.
thank you. Thank
Yeah.
you.
Dr. Ratna, ma'am, please.
Yeah, so the quality of life that has been analyzed, total number of parameters, whether they are even or odd, makes a difference.
Yes. 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 Fair enough. Yeah.
So
Okay.
because if the patient must have an option of saying that I have no comments to make on it.
Right. Okay, that is lacking in this scale. That's what the point you're making, that this scale. Yeah, I hadn't noticed that. Yes, that's a point. Naz, ma'am.
So, sir, one point I would like to make is that though this is a recent paper, they should have gone for a sentinel lymph node biopsy rather than going for an axillary
Yeah, that's
lymph
a
node dissection
definite.
for all the patients.
Quite right. We mentioned that. Yeah, yeah. Okay, Ramakrishna, you have anything to add?
Good evening, sir.
Good evening.
I thought the one thing is the observer could have been blinded to avoid bias. That is not mentioned there.
Yes.
That means the data collector who is collecting, doing this survey,
Right.
he is not blinded. That is not mentioned there. And there is no sample size calculation also for this study.
Correct.
The other thing I noticed is there is a lot of attrition bias. Almost 30% of the patients.
Yeah, that comes later in the results, right? That comes later in the results. But I also have a question. How can you blind somebody when they know it is a BCS versus MRM? It's so the observer, it probably is very difficult for them to blind, I would have thought.
Sir, that global, those are general questions. No? Those some of the questions they apply to everyone.
Yeah. Global is fine, but in the specific thing, there could be a problem. You know, there is another score for particularly for the cosmetic score. It would be very difficult.
Some of the questions, yeah.
Yeah,
Yes, sir.
and also the other thing is it's very obvious that there can be in cosmesis, there can be no difference, there can be no controversy about, the asymmetry in an MRM. So the only thing is if you have a very big BCS, then it may add to a degree of asymmetry. And as I said, even there, while you can talk about quality of, quality of life scores, in terms of assessing the cosmesis, blinding would be difficult in this situation. Ravi?
Sir, another thing, the mortality assessment at 3 years, I think that is not enough for assessing the carcinoma breast, because we always calculate 20 years.
Absolutely.
results.
So
But they have mentioned that themselves.
Yeah.
They said the mortality,
Follow-up
the study
is-
needs follow-up is only 3 years.
Sure.
I think the other thing I have noticed is that the Cosmesis Harris score is generally applicable, as you said, to the European and the Caucasian population because of the configuration of the breast, the color, and all those things, which they say that some study from Japan has, a couple of studies from Japan has said that the scores need to be modified for the Orient and the Asian population, which they have not done. If they are, because they are, I think it's obvious that cosmesis in MRM, unless you have done a breast reconstruction, will obviously suffer compared to the BCS.
Yeah.
But in terms of showing that BCS is actually very good, and most of them fall in the excellent to good category, you may need to follow something, as you said, the score, just like most of the other things need to be modified to the Orient and the Asian population.
I'm not aware of any other scores, cosmetic scores for Asians or the.
There is one, something
is
called
one?
Yes, there is one, some Japan.
Okay. I'm
from
not aware of
Japan.
it. Okay.
Yeah, but I forgot the name of that.
All right.
It is named after a city, I think.
All right. That's nice to know. We'll look it up. We'll look it up and see if there is something there. Okay, Indraja, please continue.
Yes, sir. So most of the points were covered, sir.
Yes.
Yes. Can I continue, sir?
No, just mention it again as a summing up. Yeah.
Yes, sir. It is a recent study and relevant topic. It includes good inclusion and exclusion criteria, sir, and endpoints were clearly defined.
Yeah.
And it is a retrospective study. It has a low impact factor, sir. And as Ramakrishna sir said, there is no sample size estimation.
Quite right.
Yes.
See, the impact factor also,
Yes,
is this listed in Medline, for example?
What?
The indexing, which index does this paper come in? Does it come in Medline?
No.
No. So what does it come in? That is something you must check always, whether it is an index journal or not, because only issues, only things that are in indexed, properly accepted index journals are of value. Okay.
Okay.
3 very commonly accepted indexes, if you want to call it that, are, what are the 3? You know about it, Indraja. We have mentioned it before in previous discussions. Medline, Scopus, and DOAJ, Directory of Open Access Journals.
Okay.
These are the 3 main ones. There are many other indexes. I think Index Copernicus was earlier accepted by the MCI, but I don't think the NMC accepts it anymore. Okay, this particular, I looked it up because it was an unusual journal. It is indexed in Scopus, so that is an acceptable index.
Yes.
Okay, so
Okay.
that is something which you must bear in mind when you do a journal club. Okay,
Okay.
please continue.
And coming to the results, in MRM, there were 123 patients, and 5 patients were dropped out at the end of 1 year after the surgery, and 18 patients were dropped out at the end of 3 years. So 100 patients were included in the study. And in BCS group, out of 136 patients, 6 patients were dropped out at the end of 1 year, and 30 patients were dropped out at the end of 3 years after the surgery. So 100 patients were included. So there was no statistical significance in terms of age, menopause, and other general data between the two groups. And when comparing to the BCS and MRM group, BCS group had significantly shorter operation time and shorter the hospital stay, smaller incisions, and less intraoperative blood loss. Patients in both groups were presented with subcutaneous hemorrhage, subcutaneous effusion, infection, and upper limb edema. And there is no skin flap necrosis in BCS group, and one patient had flap necrosis in MRM group. And the total complication rate is less in BCS group when compared to the MRM group. It is around 6% versus 16%. And in aesthetic outcome was poor in MRM group, and BCS group has excellent and good rates when compared to the MRM group. And there is no significant difference in terms of local recurrence rate, distant metastasis, and mortality rate at 1 and 3 years post-operatively. And at the end of 1 and 3 years post-operatively, the scores of emotional functioning, body image, sexual functioning, and global quality of life were significantly higher in the BCS group when compared to the MRM group. And the scores of emotional functioning, social functioning, body image, and sexual functioning, global quality of life at the end of 3 years post-operatively were significantly higher when compared to the 1 year post-operatively.
Go back one slide.
Yes, sir. This
one back.
Mm.
Yeah. So what is not present here, which was present in the subsequent slide that you talked about?
Social functioning, sir.
Correct. What does it refer to?
So like patients are like adapted to the changes, sir.
So there wasn't much change in the social functioning.
Yes, sir.
How did that come about? How do you think it came about? The women had learned to use some kind of a prosthesis.
Yes, sir.
Okay.
Yes, sir.
Keep, even a pad just under the bra, so that they could manage in their social interactions, go out and behave normally.
Yes.
Whereas the lack of body image led to emotional issues, sexual functioning, and they generally were less happy with themselves than the people in the BCS group.
Yes.
So that's one area. Social functioning was one area where they did manage reasonably well.
Yes, sir.
Okay, go on.
Yes.
All right. Before we go to the critique on this, Naz ma'am has a question. How was volume loss managed? Do you understand that question?
Yes,
what is volume loss? If there is asymmetry in a BCS,
yes, sir.
or when there's a lack of a breast in an MRM, how did they manage it?
They didn't mention.
Does the paper mention it?
Oh, sir, they didn't mention.
It doesn't. So just mention it. It is not mentioned in the paper.
Yes.
So one presumes indirectly through that so-called better social functioning that they had some kind of an external prosthesis.
Yes.
In the MRM group, and probably the asymmetry was not so bad in the BCS group that they could just manage by themselves. And Ravi has made it, Japanese Savai group cosmetic evaluation. Good, thanks Ravi, and I think we should look it up and then learn from it. So critique on this aspect, the results aspect. Abdul, have you been here from the beginning, or can you take this question?
Sir, I joined.
Joined late, so
late,
we will
yes.
Punish you later.
excuse no, we'll excuse you. Hari, go on.
Sir, first of all, both for the results, sir, for to the paper.
Yeah.
So both the groups are compared, sir, good with the good analytics applied, sir.
Okay.
And with the scales used for assessment breast aesthetics, and also good QOL scales were used
Right.
for paper.
Right.
And for against, sir, there is no data about the dropout case, like I mentioned, sir mentioned before.
Right.
That's the only thing, sir. And sir, one more thing, sir. It's not a critic though, but one doubt, sir. That
Mhm.
number of days in both BCS and MRM is like 10 and 14 days. Like this, I know, sir.
IP days?
Well, it is a 10 days in BCS and 14 days in MRM, I think, sir.
I hadn't noticed it, but if it is true, I think it's very long.
Yes, sir. That I noticed. I was not mentioning.
Yeah, in our service, they live in 48 hours with a drain in situ. So
Yes, sir.
that they come back, if there is a significant amount of drain, they come back 3 to 4 days later to have their drains removed. So they live in 48 hours at the most. Okay. Can I invite the seniors to make any comments about the results, please? If you can put your hand up, you can unmute yourself and give your comments, please. Okay, if you can start off, go on, Indraja.
Yes,
we
sir.
will discuss it after you put your points up. Yeah.
Yes. And the both groups were well compared, and it is good statistical analysis, sir. And the quality of life scales were used to compare the both groups. And to compare the aesthetics, they used a formal scale, sir, to compare both groups. And there was no information about the dropped out cases.
That is an important thing. They have mentioned about the total number of cases that got dropped out.
Yes, sir.
But the reason has not been given, and that is one important thing that is missed out. And why do you think that would have happened, Indraja? It's a retrospective study.
Yes,
There is no rocket science in this. Okay.
Yes.
It's a retrospective study, and that is not recorded in the case sheets as to why they dropped out. So they can't tell you. That is another disadvantage of a retrospective study. Yeah, go on. Next.
They didn't mention about the frequency, like how many days, like till how many days they have followed the patient, sir. Like
that is a very important thing. In all prospective studies, you clearly defined how often you see them, and what is the parameters that you check with each of those visits.
Yes.
And a uniformity of this process of follow-up between the groups is important for you to give credence or value to the results.
Yes.
So that's one thing that is lacking here. Okay.
And in telephonic follow-up, we may miss the recurrence, sir, sometimes.
Yeah. See, if you're looking at a quality of life score, you can definitely do it on a telephone, because these are standard questionnaires. Whether the patient is sitting in front of you or it's at the end of a phone doesn't matter. But in cosmesis and in recurrence, both issues, okay, they will not know. So unless you have a regular follow-up, then the recurrence rates that they have given for the two groups and the observation that they have made that there is no significant difference itself is questionable, because they haven't clearly mentioned how many were telephonically followed up and how many were followed up physically. That is another important area that is lacking here.
Yes.
Okay.
Yes.
No information about how the blood loss was calculated. Understand, there are standard methods of calculating an intraoperative blood loss, and as to how it was done, it would have been nice if they had defined it.
Yes.
Any other comments from the seniors, please?
Sir, I have a question.
Yeah, please go ahead.
Sir, they didn't mention about like when they have removed the drains. Is it important, sir?
Yes, I think that's an important point. Why do you think that's important?
Like in BCS, like if you place a drain for long times, it may affect the outcomes.
May affect?
Like cosmetic outcomes.
Yes, it could do, particularly if you put a suction drain. Yes. And also infection, the drains themselves, even if it's a closed system of drainage, drains themselves are a nidus of infection. So there should have been uniformity and a specific mention of that that procedure was followed between the two groups. Good point. Yeah. Yeah. Continue.
Yes, sir. And coming to the discussion, in comparing the BCS and MRM group, in BCS, there are better perioperative outcomes and lower complication rates. And BCS group had shorter operation times, smaller incisions, and less blood loss, and that promoted more rapid discharge. And in MRM group, the complication rates were higher because of the serious destruction of the tissues of the mammary glands. The main reasons for better perioperative outcomes and lower postoperative complications in BCS are in BCS, breast tissue invaded by single tumor that was removed and it is less invasive. And in MRM, the breast was completely removed and free flaps were used on the affected side that caused damage to the superficial fascia. And according to a study conducted by Rosenberg et al., comparing BCS versus MRM, in BCS, the quality of life slightly affected by physical trauma, anxiety, and their daily life was remained normal. And in MRM, the quality of life was severely affected by sexual life, self-emotion, and psychological pressure. So this study reveals that BCS confers a better postoperative quality of life than MRM. So according to QOL et al., they compared the aesthetic outcomes. The quality of life in patients with early breast cancer mainly related whether the breast was retained or shape of the breast was considered satisfactory. And this study showed a better postoperative quality of life in patients who are undergoing breast conservative surgery than in patients undergoing MRI. And the rate of good to excellent aesthetic outcomes in BCS group was up to 92%. It is suggesting that BCS has little effect on shape and texture of the affected breast. The indicators of quality of life at 3 years after the surgery were significantly improved when compared to the 1 year after the surgery. This indicates that postoperatively, patients with breast cancer gradually adapt themselves to the change. So in our clinical practice, prognosis is important. And this study confirms that BCS offers a good prognosis equivalent to the MRM, and because there is no significant difference in local recurrence, distant metastasis, and mortality rate at 1 and 3 years postoperatively. The postoperative recurrence rate of early breast cancer significantly reduced with development of radiotherapy, chemotherapy, and endocrine therapy. And according to De Lorenzi et al., the recurrence rate at 3 years after the BCS was about 15%. And in our study, this is about 4%. Because mainly it is due to the improvement in the adjuvant therapy and surgical resection and early diagnosis. The quality of life was mainly assessed by question. The limitations includes the quality of life mainly assessed by questionnaire survey after the surgery instead of before and after the surgery. Moreover, the scale, reliability, and validity were not analyzed in this study, so they were verified in previous studies. And this was a 3-year follow-up study, and longer follow-up was not performed.
Yeah, Indraja, do you think these are the limitations that they have themselves admitted to, which is a very good thing in any paper. When you write a paper, you're actually appreciated if you list your own thoughts about the limitations. But do you think this QOL survey before surgery is as important as they believe it is?
So, like, we have to know the like about the patients before the surgery, how is like,
which part of the QOL? You're right. Which part of the QOL that you need to know about here? We mentioned there are two segments to it.
Yeah, like quality of life 430, sir.
Global
yeah,
QOL
yes.
must be measured before and after. The breast specific QOL doesn't make much of a difference. All right, it's very rare that somebody would be looking at their in an intact breast about their symmetry and the color and the level of the nipple and things like that. They normally wouldn't do it. So what they refer to here, before and after scores, refers to the global score. That is the important thing you must understand. Okay, and reliability and validity need not be measured in every, for a scale, need not be measured in every study. Once it is established, then you can use it in other studies. And we have done it. And we have used the so-called validated scales in many of our studies, and we don't independently validate it again in our study. Okay.
Yes.
So I thought that they're being a bit harsh on themselves when they do this. And of course, the last point we have made earlier, 3-year follow-up is a very short period.
Yes.
Okay.
Yes.
Go on.
Okay.
Any points to add, please? Go on.
Yes, sir.
Go on.
Uh,
Go on. Yeah, please. Ravi, go on.
So I think what Niranjan alluded to about the the intention to treat analysis, when you are comparing the two groups, because they have said that once the margins were positive, they went on to do a MRM in such patients. So there is no data about whether those people were still part of the breast conserving group or were they treated as the thing. So because then it will add to the complications and other things, and also it may skew the mortality and the recurrence rates as well. So I think that is a
right. Ramakrishna, correct me if I'm wrong, but can you really apply strictly an intention to treat in a retrospective study?
Yeah, that's what I was almost.
Can't,
I
in my view.
opened just to tell that.
Yeah.
I don't think.
No,
it
but
is
they could have
possible
given
to
the
follow
data.
ITT.
If, for example, they would have grouped these patients as a breast conserving surgery, and then they would have known that the margins became positive, and then they went on to get modified radical.
See, they didn't start with a group, Ravi, so they don't know what happened. And also their big limitation was that they didn't know why people dropped out of their studies. The reason for it. Without it, they cannot make a comment on intention to treat or otherwise. That's one of the limitations.
Yeah.
Ramakrishna, anything to add?
Yes, sir. The intention to treatment, when you are grouping the patient, allocating the patient to either group, at that time you are going to have some intention. This patient will be in the intervention group, or this patient will be in the control group.
Yeah.
So that comes only in prospective study. In this type of study, it is. I don't think it is possible to follow it completely, sir. Here, the main bias I saw was the attrition bias.
Yeah.
Because too many patients they have removed. Almost 30%.
Yeah.
That is too much.
Yeah. Sir, that is what I said when I mentioned that about the intention to treat. Since it's a retrospective study, it will not be valid.
Yeah.
But they could have clearly described which patient went into MRM, which patient went into BCS, and how many of them got converted to BCS. It would have been good.
Yeah, I agree that is a limitation, because the grouping itself.
And I don't know. I've not seen that retrospective study word used anywhere. They've just mentioned everywhere it is that they've divided into two groups.
No, it is mentioned. I can't remember exactly where, but yes, it is mentioned that it is a retrospective study. Go on, Indraja. Yeah.
Yes. As mentioned, the points again is the study is lack of longer follow-ups. In the quality of life assessed after the surgery only. Yes. Can I continue?
Yeah, continue.
And a review of literature. According to a study conducted by Vivek et al., does quality of life among modified radical mastectomy and breast conservative surgery in patients differ a 5-year comparative study? It is a cross-sectional study. They compared the quality of life between the MRM and BCS. They used long-term quality of life breast cancer questionnaire, and they concluded that significant differences in the quality of life of women from both groups in terms of physical function and body image, with the BCS group appearing to have better quality of life. And the other study conducted by Hande, Esil et al. And published in 2014, the comparison of quality of life Turkish breast cancer patients receiving breast conservative surgery or MRM. They included a total of 100 women with breast cancer who underwent either BCS or MRM. And they concluded that patients who received BCS had better functional status and less frequent symptoms than patients who underwent MRM. So in conclusion, the BCS offers good prognosis that is equivalent to MRM, and it has a better aesthetic outcome and quality of life when compared to the MRM. So it has to be being promoted in clinically treating for early breast cancers. Thank you, sir.
Thank you. I think you did a good job, Indraja, particularly in dishing out 2 or 3 papers from the southern hemisphere, from our part of the world.
Actually, this is from Bangalore, sir. This
Yeah.
paper.
Okay. This and, Turkish paper and things like that, where there is some data about the QOL between a comparison between BCS and MRM. But as you know, in journal clubs, one of the points that you note is to get ideas for your own study. And because there are so few papers on quality of life after BCS or MRM, that is something that all of us can consider, have a prospective study over a period of time to see how you can get some more Indian data on the subject. Lymphedema, Nas says lymphedema is a major factor and says you must have SLND as, should we think about it, think of it as a standard requirement. Totally agreed. I think today's standard of care is SLND. Unless you have clinically palpable, radiologically proven large nodes, which are characteristic of a neoplastic infiltration, you do not do an axillary dissection, an axillary clearance. So in non-palpable nodes, you have to do a sentinel node biopsy. It's easy enough to do, and we practice it. And while some of the newer methods like indocyanine green or even a Geiger counter and radio active material is difficult, you can definitely use methylene blue and get a reasonably good indication about where the sentinel node is. At this stage, we usually invite the seniors to give their comments about the presentation and about the way it was done. Can I invite Dr. Ratna Chopra to start, please?
So it was a very good presentation. And what I liked was the critiques and points for and against. I would want to share the way we used to conduct a journal club. We used to do it in 3 ways. Is this new? Is this right? And should we change?
Yeah.
So one last slide can be added on. If whatever we have concluded from this presentation can be implemented at our place of work.
Yeah, absolutely, man. We do it all the time. We didn't mention, you're right, absolutely right. Is this what we are doing? And if it is not what we are doing, should we change?
Yeah.
Absolutely, absolutely.
Another thing that I wanted to say was that this paper makes no mention of any immediate or delayed reconstruction that is undertaken in any patient. Yeah. Because even after MRM, if you do an immediate reconstruction, quality of life may be just about the same. So probably some kind of reconstruction could have been made by the authors.
Very true, very true. Point well taken.
I really enjoyed the journal club, sir.
Yeah. Thank you very much. Sopimat?
I've been enjoying the discussion, and it's a nice presentation and a lot of inputs by the colleagues. I really admire the youngsters. They have picked up so much of nonsense of journal club presentation, and I really appreciate it and wish to attend again and again to learn myself more.
Thank you. Thank you. Ram Krishna?
Yes, sir. Yeah, nicely presented, sir. And almost all good points are made out. And as Madam said, I think that last slide we should have asked that question. Can we implement this in our practice?
Yes,
that's one.
Very true.
That's fine.
Is Madhumita madam still there? I don't see her name in the. Ma'am, are you there? Dr. Madhumita? No, she might not. She might have left. Niranjan?
Sir, good presentation, sir, and good inputs. And to that point, why probably we didn't ask is because already we are doing sentinel lymph node as well as BCS.
That is
so true. That's why that probably that question was not asked today.
Yeah, that's right. Yeah, Srikanth?
Same, sir. Excellent presentation. Nothing to add.
Okay.
Very good.
All right. Ravi?
Yeah, I think good presentation by Indraja.
Thank you, sir.
I think the BCS has become a standard of care for a long time now. So probably that question is probably not relevant. That's why I think it is not.
The reason we even chose the chose the paper was to impress upon all of us again and again that quality of life is something that we should measure objectively. And in many papers, this data is lacking. And so this is to remind ourselves that quality of life is important. And I think, Indraja, you did a very good job. Congratulations. And I would like to thank all of you for participating, particularly the senior faculty, our guests. Ma'am, we will keep you posted about our academic program in our DNB course. And we would very much appreciate if you can spare time, participate and contribute. We would really appreciate that. Thank you very much, and good night, everybody.
Thank you. Good night.
Good night.
Good night.
Good night.